Kenneth, and you've joined our PCPCC webinar, which we've entitled Comprehensive Medication Management as a Critical Component in Coordinated Care Systems. And we're really fortunate today to have two phenomenal speakers joining us from CMS to share some of their views. I did want to mention that this is being recorded, and the recording of this is going to be available within 24 hours. Also, just to note that the PCPCC, our conference in D.C. is occurring next week, so if there's any of you on the line that have not signed up for that conference and still want to go, please register for that. We've got a great turnout, and I think we've got a phenomenal lineup there. Also, if any of you have questions while we are on this webinar, you're in listen-only mode now, just post those questions. We'll try to get to as many of them as we can, and Dr. Isitz is going to give you further instructions at the end of what to do if your questions don't get answered today on the webinar. But with that, let's get started. First, I'm going to introduce Dr. Brian Isitz. He is then going to introduce John O'Brien. But Dr. Isitz has been a professor for many years in the Department of Pharmaceutical Care and Health Systems at the University of Minnesota College of Pharmacy. And he has just recently been a fellow at the policy fellow at CMS and is now with the Innovation Center at CMS. So if we begin to look at his list of expertise, he asked me not to get too overglowing with what he's done, but he's really been at the heart of the coordination of medication in patient settings for quite a while. He's written several articles that are really seminal articles on that as part of his research. One I like to mention was entitled Clinical and Economic Outcomes of Medication Therapy Management Services, the Minnesota Experience. That was actually published in 2008 in the Journal of the American Pharmacist Association. And his expertise in the scholarship of caring and specifically studying outcomes of medication management therapy services has really been provided in integrated team-based care settings within the University of Minnesota. His research interests continue to focus on the exchange of electronic health information to redesign the nation's medication use system. And he's currently serving as a co-investigator on a 3-year National Library of Medicine HIT grant titled Semantic Relatedness of Active Medication Safety and Outcomes. And as I mentioned, he is currently serving as a policy fellow for CMMI. So with that, it's so great to have somebody who's not only done the research but taught students but has been in the practice of what we all like to call comprehensive medication management to actually share some of his sites at CMS. So with that, I'm going to turn it over to Brian.
Well, thank you, Terry, for that wonderful introduction and the invitation to facilitate the Patient-Centered Primary Care Collaborative monthly seminar discussion. The title of today's collaborative workshop discussion is Comprehensive Medication Management as a Critical Component in Coordinated Care Systems. I'm honored and privileged to be able to serve in this capacity today because, as Dr. McGinnis noted, I've been afforded the opportunity to extend my sabbatical as a health policy fellow at CMS, working first with the Medicare Drug Benefit and Part C and D data group, and now at the Innovation Center. The chance to work at CMS to improve our healthcare delivery system generally and the use of medication specifically is very special. Please allow me to begin by providing you with an overview of the flow of today's workshop. I will provide a few opening remarks to thank everyone for their contributions to the significant task before us and to set the tone for today's session as a collaborative learning process. I will then introduce my co-presenter, John O'Brien, who will take you through an overview of the current Center for Medicare and Medicaid Initiatives, and I will then focus on the importance of comprehensive medication management in coordinated care systems. Well, first of all, I want to extend a thank you for the hard work that you're doing to improve our nation's healthcare system. For each of you, for those of you who are care for patients and work to improve the quality of care delivered to those patients, make our healthcare system safer and more effective, a very big thank you. I've been in your shoes, and I really thank you very much for your contributions. I also want to mention the Patient-Centered Primary Collaborative resource manual on comprehensive medication management. That's for those of you who may not have read it. It's in hard copy as well as online. it's an extremely well-written document to help guide us in understanding how comprehensive medication management fits in coordinated care systems. And I want to thank each of you for being a part of this critical dialogue. We've had over 300 individuals register for this particular webinar, and I kind of joked I probably know half of you folks, and the other half I'm looking forward to meeting you. We're ready as never before for a leap forward into a healthcare system that we want, need, and can have. And we do value your insights and commitments, and to achieving our mission. And when I say commitments, we love what you're doing, and we want to better understand your work. And with that, I'm going to turn this over in just a moment to my co-presenter, is Dr. John Michael O'Brien. Has a PharmD and a Master's in Public Health. He is currently the Director of Field Operations for the Center for Medicare and Medicaid Innovations. And appropriately, as the Field Director he's currently in the field today, and he'll share some of his work in the field as well. But John is a very special individual. He has been my peer mentor and colleague when I came here to CMS, because as a person from academia, I really didn't understand all the special ins and outs of working within the government. And John has been a tremendous asset with a breadth and depth of experience across the healthcare industry, has been in here in Washington, D.C. for over 10 years, and is really, really a gift to the Innovation Center. And with that, Dr. O'Brien, you're on.
Wow, thanks, Brian, and thanks, Terry, and really thanks everyone at the Collaborative for giving us this opportunity today. I'll also thank everyone on this call. I'm just astonished by the number of experts and the names of the experts that are actually on this call. So I'm grateful that we probably won't have to go into too much detail, because I'm sure there's folks on this call that know far more about some of these topics than I do. But it's a real treat to be at CMS right now. CMS is changing, and it's been really exciting to sort of watch the agency embrace a spirit of boundarylessness and unconditional teamwork, and really ramping up our customer focus as we do a better job of sort of serving our beneficiaries. When Dr. Berwick came in, he really got us focused on a new vision for CMS, and we all believe that CMS is a constructive force and a trustworthy partner for the continual improvement of health and health care for all Americans. And as we work towards that vision, every day we're really guided by our aims. Many folks, of course, are familiar with the three-part aim of better health for individuals, or better health care for individuals, better health for populations, and ultimately lower costs through improvement. And those are the aims that we really focus on a daily basis. Of course, being a quality-focused organization, it's essential for us to be focused on our measures of success. And some of those are listed here, where we really have an opportunity to sort of get down to the most granular details of things like the IOM 6 domains for quality, and the opportunity to focus on sort of the population-based outcomes that underlie poor health, or the key determinants for those of you in the public health space, and then ultimately being able to demonstrate that we have the ability to lower costs through improvement. And the ability to do so is particularly more important in these challenging financial times, where states and systems are forced with tough decisions to make about whether to continue to offer benefits or services to certain populations. And we really do believe that there's an opportunity to continue to serve more people by lowering costs through improvement rather than cutting programs. We do believe that the United States has the greatest acute care in the world. There's no debating the fact that people come from all around the world to be treated. But we recognize that even today, still 46 million Americans lack coverage, and those that do have coverage often find themselves in a fragmented delivery system with variable quality. There's pockets of success across the country, but as you start to look at that on a large map by hospital referral region or other part of the country, you can really see that quality is scattered across the country. The current system may not be as supportive of patients and physicians, or even patients and physicians working together. And unfortunately, as many of the folks on this call know, the costs that are rising at twice the rate of inflation really create an unsustainable healthcare system, which is why the work of the Collaborative has been so appreciated over the last few years in sort of shaping reform. Now the opportunity to implement reform has been a real treat for all of us at CMS. I've particularly been fortunate to work on a number of patient safety initiatives at CMS, and always want to begin with the picture of the patient. Unfortunately, Josie King, shown here with her mother, Sorrel King, highlights another failing of the U.S. healthcare system, and that is that care isn't always safe. And we see pockets of improvement across the country, but unfortunately, oftentimes patients are harmed by the care that they receive. And the data on these can be staggering. On any given day, 1 out of every 20 patients in American hospitals affected by a hospital-acquired infection. Among chronically ill adults, 22% report a serious error in their care. The Office of the Inspector General late last year released a report that showed that 1 out of 7 Medicare beneficiaries is harmed in the course of their care, and a subsequent paper in Health Affairs suggested that may happen even more often, and that the government is spending on average about $4.4 billion every year to treat the problems that are caused by harm, in addition to the health problems that actually brought people to the hospital. So as you can see, medical harm has a high human cost and has a high financial cost. And unfortunately, despite pockets of success, we still see massive variations in the quality of care and no major change in the rates of harm and preventable readmissions over the past decade. But these pockets of success give us hope. We believe that we can do better, and ultimately believe that we must do better as we work to design a future system that provides affordable, accessible care, not just access to care, but access to information to make better decisions, care that's seamless and coordinated across the care continuum, that provides high-quality care that is also person and family-centered, that begins and ends with the patient and their family in mind, and is supportive of clinicians in serving their patients' needs, and ultimately those clinicians that want to work to implement change and to build upon the successes across the country that have given them hope. So we do believe that the United States of America has a long history of invention, and we believe that we can invent our way to success to transform healthcare. We really do believe that we can build on our history of invention to innovate our way to a sustainable, proud, and excellent American healthcare system that isn't just known for its high-quality acute care, but is also being able to meet the goals of the three-part aim. So ultimately, again, we'll just sort of get back to this point that better care will ultimately be less costly care, and there'll be less human harm and less financial harm as well. And that was really the foundation for the meaningful use rules, and the healthcare transformation that meaningful use brought about really began to lay the infrastructure for the work across CMS, HHS, and the federal family. And as you'll see, as the meaningful use rules and incentives continue to be implemented and uptake continues, that will move from an infrastructure that allows data capture and sharing to ultimately the ability to build systems such that that data can be used to support advanced clinical processes or identifying at-risk populations or pockets of harm. And then ultimately will continue to grow such that we have the ability to see improved outcomes as a result of these data and these advanced clinical processes being used in the field. This infrastructure is essential to supporting the new tools in the CMS Toolbox, and as a result of the Affordable Care Act and other activity and the hard work of thousands of people across the agency and the federal family, we're now beginning to implement programs like medical homes. We've had payment changes that will actively work to reduce hospital-acquired conditions via a series of incentives and disincentives. We've begun to release rules that support value-based purchasing. We've had a strong focus on reducing fraud, waste, and abuse. And in the last year, in addition to launching the Innovation Center, we've also launched the Medicare and Medicaid Coordination Office, which is working very hard across the country, not just in Washington, but in states as well, to be able to align our programs and work to coordinate the care that's provided and the payment that is used to provide care to those who are eligible for both Medicare and Medicaid. Of course, we're very grateful that Section 3021 of the Affordable Care Act created the CMS Innovation Center, and many other folks across the agency have been really working very hard to implement one of the more prominent activities in Washington right now, and that is the Medicare Shared Savings Program, or the Accountable Care Organization rules. So again, to sort of bring this all together, we believe that innovation has the opportunity to transform American healthcare, and if you've ever had the good fortune of seeing Dr. Rick Gilfillan, our leader, speak at a presentation, he'll he'll often begin by doing what he calls the innovation wave, right? He'll have his hands to the left, and he'll say, here we are in our current state. We have a producer-centered care, and the current payments are part of the problem. We pay for care. We pay for episodes of care. We don't necessarily pay for quality or for improved outcomes. And then, of course, he'll make a big shift to the right, and then he'll talk about the future state, where all Americans receive the right care in the right setting at the right time. And the Innovation Center is only a small piece of this, and we're very privileged to have the opportunity to work, again, across the entire Department of Health and Human Services and with our partners in the private sector to ultimately build the future state in which CMS is part of the solution. Our rules and our payment methodologies support quality care and ensure that our health dollars are spent efficiently to be able to improve quality. The Innovation Center's mission is very similar, of course, to that of CMS, and the statutory purpose was to test innovative payment and service delivery models. And I really want to just focus on the fact that, again, we are testing innovation that will ultimately reduce program expenditures under Medicare, Medicaid, and CHIP without harming quality. So we are looking to test and then ultimately scale up those innovations in care that are budget neutral and quality neutral. And Congress gave us $10 billion in funding over fiscal year 2011 through 2019 to do so. And by scale up, I think there's two ways to focus on that. One is the opportunity for us to lead campaigns to identify pockets of success and to take the best practices that we see in those successful areas and teach them across the country. But ultimately, we have a new rulemaking authority in the Innovation Center and in the department, such that when we find those models that are budget neutral and are quality neutral or save money without harming quality, and the Office of the Actuary certifies that did indeed happen during the testing of our models, we then have the opportunity to implement those models into CMS rules via rulemaking. So some could say in the past, the time from innovation to implementation of a new demonstration program involved about 13 years and a number of back and forth to Congress, whereas in the new Innovation Center way, there's an opportunity to identify promising models, to test them, to evaluate them, and then scale up the most successful ones. The Innovation Center strategy is really focused on three I's. We're focused on incentives, the ability to test models that align payment and administrative approaches that support the three-part aim. So in many ways, that's focused on payment. We have a large group of people who are focused on learning and diffusion, such that we support the development and the diffusion of our three-part aim knowledge, models, and operational activities. And what that means is we want to make sure that everyone who has an opportunity to participate in our programs understands what the programs actually are. So there's not sort of that lag at the very beginning in trying to figure out what to expect when a new program comes out, but rather those who are aware of the model and feel that they're a good fit for the model have an opportunity to participate in advanced learning. And then that diffusion ultimately is what leads to the results in the field. And then, of course, we are very focused on the capturing of ideas, and we are constantly trying to drive development of new ways to deliver on and discover the three-part aim outcomes. And if you haven't been to innovations.cms.gov to learn about the things that we're working on or even submit ideas of our own, or of your own rather, I'd encourage you to do so. This slide here really sort of demonstrates sort of the pipeline development process. We have sort of a broad funnel, and everyone in the agency and across the country is encouraged to submit ideas. We get those ideas not just from the Innovation Center and the agency and stakeholder groups such as yours, but also individual innovators in the healthcare professional or large provider community. And when we hear those ideas, we work really hard to sort of define what the model actually is. What is the concept? And that leads to the development of a short proposal, and then we have an opportunity to go back out to all of you and say, hey, what do you think of this idea? What are we missing? How would you improve it? And then that ultimately leads to the prioritization and the building of an advanced finalized model, which we then oftentimes will have the opportunity to release via a solicitation on the innovations.cms.gov website and invite you either via a broad funnel approach, which is you pick how you're going to solve the problem that we're seeking to improve, or a narrow funnel approach whereby we're asking you to test very specific activities. Our initial work on models has focused on a number of activities. We launched with the multi-payer advanced primary care practice demo, or the multi-payer medical home demo, a companion FQHC demo program. We've recently launched the comprehensive primary care initiative and a number of other activities. And I really want to just highlight the two programs that I'm lucky enough to work on. The Partnership for Patients, a $1 billion investment in improving patient safety over the next 3 years, and the Million Hearts Initiative, which is a new program across CMS, CDC, and HHS, a public-private partnership to prevent 1 million heart attacks and strokes over the next 5 years. This slide here really, again, sort of summarizes sort of where we've gone thus far in this conversation, beginning with the building of the meaningful use infrastructure and ultimately progressing through delivery reform, global payment, or improved models of capitation. We have an opportunity to test, whether and how giving providers an escalating amount of risk can lead to, again, the achievement of better health care and lower cost through improvement. And we also have a number of tools that support and empower learning and redesign, such as the ability to share data across programs, to develop learning networks or collaboratives, and a number of other activities. So I'm going to just transition very quickly to the Partnership for Patients, which was launched by Secretary Sebelius on April 12th of this year. It's a new public-private partnership that seeks to achieve a 40% reduction in hospital-acquired conditions over the next 3 years, and ultimately a 20% reduction in 30-day readmissions over the next 3 years. If we are successful in achieving these aims, we have the potential to save $35 billion over the next 3 years, and as you can see, ultimately help millions of patients avoid injury, recover without harm, and save a number of lives as well. And we're very grateful that nearly half of the hospitals in the country thus far have signed the pledge as we approach our 6-month anniversary. If you haven't had the opportunity to visit healthcare.gov/partnership for patients, we welcome you to do so. And while you're there, you also have an opportunity to learn about the Community-Based Care Transitions Program, a $500 million program to help hospitals and healthcare organizations partner such that community-based organizations and hospitals can partner to address the root cause analysis in communities that lead to greater readmissions, and ultimately receive or design and receive payments from Medicare for the services that lead to fewer readmissions. And again, this isn't a grant program. This is actually the opportunity for community-based organizations who are eligible to enter into provider agreements with Medicare, whereby Medicare is paying per eligible discharge to prevent readmission. More information, again, is available at the Partnership for Patients website. I'm going to just run through very, very briefly a couple of our newer models that may be more interesting to folks on this call. The ability to test bundle payments for care improvements, and again, that the opportunity to sort of bring together all of the costs that would be associated with an episode of care and provide them prospectively in a number of ways to the providers, such that they can actually have an opportunity to provide care under the cost of the bundle that's provided to them. And then the most recent initiative, the Comprehensive Primary Care Initiative, a new CMS-led multi-payer approach to improving and strengthening primary care that will use a approximately $20 PMPM payment up front to ultimately bring together a number of systems across the primary care continuum that, again, sort of begins with a PMPM payment, but ultimately leads to a smaller PMPM that brings together a shared savings opportunity, or, again, sort of a partial capitation model. I'm going to just mention, but really not speak too much to, the Accountable Care Organization initiatives at CMS, given that we're in that particularly vexing space between a proposed rule and the release of the final rule. But again, the shared savings program led by our colleagues in the Center for Medicare combines with the Pioneer ACO model, or a accountable care organization model led by the Innovation Center with different rules that really spurs to action those entities that believe that they're ready to be on the cutting edge of being an ACO and get started right out of the gate. We're also considering a model known as the Advanced Payment Initiative, which will test whether and how paying in advance a portion of future shared savings has an opportunity to, again, stimulate participation in and success with the ACO model. And all of these models are supported by a number of accelerated development learning sessions, as I mentioned earlier, whereby we bring experts out into the field to work with those who are ready to be ACOs and are considering participating in the programs such that they have the greatest opportunity for success out of the chute. So I'll stop here and say that our work continues. We've had the opportunity recently to look towards the coming one-year birthday of the Innovation Center and ask ourselves what priorities we'll be working on in the near future. What are some of the models that we'll be testing? And again, we can say that we are seeking innovative ideas from the stakeholder community, from the innovator community, from the provider community, that improve and facilitate coordinated care, that promote better primary care, that align incentives and discourage the use of perverse incentives that actually result in payment that isn't based on outcomes, that increase efficiency and decrease unwanted variation. And of course, we really want to make sure that we're actively engaging patients and communities such that we're fostering wellness and prevention. This is where I can't help but say how lucky it is to work with Dr. Isaac here at the Innovation Center because of the fact that all of the innovation in the world and all of the models that we're testing don't have a hill of beans chance of success if patients don't use their medications appropriately. And not only is Brian someone who really understands the ins and outs of medication use from a health system perspective as well as a patient perspective, he's had the good fortune of training under Vicki Oates and Michelle Ketchum and their leadership and their team in the Medicare Drug Benefit Group. And we're very lucky in the Innovation Center to have a strong relationship with them and to continue to ask as they roll out their successful and their exciting innovations to the Medicare Part C and D programs, including the coming changes to the 5-star rating system and the quality bonus payments, to ask ourselves how can we work more closely to improve comprehensive medication management. So for that, I'll again say thank you for the opportunity to briefly outline some of the work of the Innovation Center and to turn it over back to Brian.
Okay, thank you, John, very much. Appreciate that overview because there is really just highlights the extensive amount of work that has gone into the various aspects of the Affordable Care Act. And it is truly amazing to be a part of that and witness that. So let's now look at a focus on medication management in coordinated care systems. A couple of first things, three things I want to highlight. And the first two are we talk about commitment and engagement. And I mentioned commitment means we're very interested in the models, the innovations, the work that you're doing, and we want to understand it better. I've had the good fortune to be involved in some care model innovation in Minnesota, for instance, with the Fairview system, the Mayo system, Hennepin County Medical Center, for instance. There's much going on throughout the Midwest, but all over the country. And that privilege to be here at Medicare and talk to individuals who are equally as innovative, if not more so. Folks in Seattle have at the Group Health Cooperative, or another example that have come to mind of individuals that have introduced medication management into care model innovation, studied it, are demonstrating outcomes, and also then outcomes that relate to our three-part aim. And so there's those commitments, engaging you in the folks in the opportunities that that John began to outline. And then the third piece here is to just briefly talk about the national quality strategy. And I look at this as my touchstone. Some days you get involved and you look at everything that's going on around you and you almost feel overwhelmed. And I go back to what I call the roadmap. And it's a report issued to Congress of March 2011 on the title, the National Quality Strategy. And it really outlines the initiatives, the emphasis areas, And as you see these programs develop and are rolled out, you can actually see where they are on the roadmap. And so I find that very useful. If you get a chance, please do so, pull that up, the National Quality Strategy, and read through that. I think that's so important to guiding the work that and the journey we have before us. And so the effective and safe use of medications is, as we all know, critical to achieving the three-part aim of better care for individuals, improved health for populations, and at a lower per capita expenditure. There's a significant body of evidence that describes the benefits of coordinated medication management. We don't need another randomized controlled clinical trial. It's really, we're at the point now where let's look at models that are successful, let's define the outcomes, and then scale those up. Comprehensive medication management is essential in designing a medication use system to help patients achieve intended goals of therapy and to resolve drug therapy problems impeding progress towards goals. And I did mention at the outset the importance of the Medication Management Task Group Resource Manual in really describing what comprehensive medication management is so that there is no ambiguities in that service. And the social need is related to drug-related morbidity and mortality, which is costing this country over $200 billion a year. I want to talk about some of, and getting back to the National Quality Strategy, it really talks, there's the emphasis on both intergovernmental and external stakeholder input and cooperation. And the first meeting that I sat in every Wednesday at 2 o'clock Eastern Time, there's an intergovernmental meeting in what's called the War Room of the Switzer Building in downtown Washington, D.C. And every government agency that's involved in improving our medication use system is a part of this. The first meeting I sat in, I've got it circled on my calendar, was August 3rd. And I sat almost like a fly on the wall and said, oh my goodness gracious, I can't believe what I'm seeing. I said, I would hope that someday, within agencies would talk to each other. Not only do we have that, but across agencies. So if your favorite federal agency isn't on this list, it's an omission on my part, but I just wanted to highlight a few of those. The Agency for Healthcare Research and Quality, not only do they have the medication management evaluation, but they also then head up the data and measurement work group on the Partnership for Patients. The Centers for Disease Control, you go onto the CDC website, has a medication management evaluation project. One of the ones that many have heard on this phone call related to the Health Resources and Services Administration, Patient Safety and Clinical Pharmacy Collaborative. That's a very prominent aspect of the QIO, the Quality Improvement Organization, 10th scope of work, and I've had the opportunity to work closely with HRSA to really to highlight the exemplars in our PSPC in the PSPC network, so that we can bring those that model to other folks to go to scale. I do want to mention the Part D Medication Therapy Management Program, 2011 MTM fact sheet. Michelle Ketchum, Vicki Oates, and Gary Worth and their colleagues did a wonderful job putting this this year's fact sheet together. And near the end, it really lays out, gives even a roadmap of some of the questions that they would seek to answer in the future. I want to talk briefly about the Office of the National Coordinator. We have the Beacon program communities. There are 17 Beacon communities to help integrate the health information technology, and we have a number of pharmacists in various Beacon communities working to actually tie these medication management pieces that need to be tied together through our electronic health record. And also mention the Food and Drug Administration, the FDA Safe Use Initiatives, so that all these partners, including the VA, Department of Defense, are all together as we learn from each other. Because as Dr. Berwick says, no one of us has all the answers, but working together, we can find the answers. Okay, so CMMI initiatives that can benefit from medication management. John talked a little bit about the community-based care transitions applications, and I can't speak strongly enough about these opportunities. We know that there are a number of pharmacists engaged working with community-based organizations to submit applications. Community-based organizations, for instance, are local area agency on AAA, area agency on aging. Almost a third of those have some interest in becoming serving in this capacity. These are for innovative services which are not currently reimbursed by Medicare. So comprehensive medication management services and care transitions is vitally important. So here's an important one. John mentioned the Million Hearts Initiative to measure improvements in the ABCs, aspirin use, blood pressure control, cholesterol management, and smoking cessation. I think what's interesting is I'll give a story back. Our students back at the University of Minnesota, pharmacy students, have latched onto these ABCs, and it's the Centers for Disease Control and CMS websites. Both are tied together to outline this initiative and the goals, and our students have run with this, and it's very exciting. I'll be going home next week to kind of put my eyeballs on the programs and initiatives that they're building in relation to this initiative as well. Medical homes obviously benefit when patients use effective and safe medications as intended. Accountable care organizations. If we're not accountable for the drug therapy outcomes and we have drug-related morbidity and mortality, it would certainly impact our ability to achieve the goals of accountable care organizations. And in the Partnership for Patients, we have the aims to reduce hospital-acquired conditions. Over a third are adverse drug events, and then to decrease readmissions. Now, one of the things that we're doing here at CMS is to reach out to our stakeholders, and the CMS has asked me to work with our pharmacy community, pharmacy stakeholders, to kind of have these collaborative sharing programs throughout the country. And so here's a smattering of the partnership that may be coming to a pharmacy meeting near you as early as this Friday. That'll be the Academy of Managed Care Pharmacy. Mary Andrawis is a pharmacist with an MPH. Who's working at CMS. She'll be at that meeting. So for the early risers on this Friday, it will be our first program. Dr. Berwick has a videotaped address that he'll be delivering to the American College of Clinical Pharmacy this weekend, thanking pharmacists for their contributions to our goals and aims. The American Society of Consultant Pharmacists, I want to make a note here. They called last night, wished to move the program to November 18th, which is the Friday. There'll be more information forthcoming on that. And an exciting program at the American Society for Health System Pharmacists mid-year meeting in New Orleans on December 7th. And one of the things that we're really looking at is our engagement experiences. I come from a traditional academic environment where you teach, you ask questions. That's the old model. The new model is, oh no, we are looking for your insights, actually discussing what works and how we resolve challenges. And it's a whole new set of skills and techniques that CMS is teaching a professor from the University of Minnesota, which certainly is so beneficial in this effort. And before I'm going to ask you for your suggestions and input in just a minute, but I want to have, if John, you just touch on the Care Innovation Summit coming up on the 26th of January.
Oh, well, thanks, Brian. On January 26th, we have an opportunity to showcase really innovative projects that are pursuing the three-part aim. We've invited or encouraged the contribution of models via sort of an outreach process. You can learn more about how to register and apply to present your work by going to don't type www, just go to hcidc.org. And one of the questions that has come up is, do I have to be there in person? And I've learned that we have a number of innovative approaches to beam people into the meeting, including Skype and other approaches. So hopefully you'll have an opportunity to join us on January 26th in Washington, D.C. At this co-hosted event to see and to learn about the innovations that are happening across the care continuum. Hopefully you'll submit a model that will ultimately be selected, and you'll have an opportunity to present your exciting work to the fantastic audience that we're going to have gathered.
Great. Thank you, John. And then really want to say that America needs a people-centered, coordinated, sustained, and reliable healthcare system, and I'm going to ask you to join us in creating this vision. And what I'd like to do now is over the last 2 months, I've actually watched how the team here at the Innovation Center and the Partnership for Patients and the Million Hearts Initiative actually works with stakeholder groups. And we'll be doing this virtually because we certainly can't, we're not in person, but if we were in person, what would happen is that there'd be, each individual would be given a piece of paper, which I thought is affectionately referred to as a script. Not a prescription script, but a script where you'll actually will describe your insights and recommendations for how you can contribute in these areas. And so I'm going to ask each of you to send me. I'll give you my personal email at CMS and my direct telephone line to share your insights, suggestions, offers of the work that you're doing, so I can be that person to gather what are some of these the models of comprehensive medication management we may not even be aware of that are going on, and some of the results that are accruing, because we don't have time to wait for a study to be published. We need to get the results forward now. And so with that, I'm going to stop for a moment and ask Dr. McGinnis to step back in.
Okay. Well, thank you so much, Brian and John, for your thoughts. I'm looking at some of the questions here, and this one may have been partially answered by the Care Innovation Summit, but we have one question that says, how does a person with an idea get exposure to a set of ideas that they have developed? So I don't know if the question is quite around, are they asking, can all of us begin to look at these ideas that are coming into your idea engine, and you know, how can others sort of be a part of those ideas?
Well, thanks, Terry. That's certainly an excellent question, and I would say that the Care Innovation Summit is one way that folks can see what's being worked on. We're also very fortunate to have a number of partners across the federal family and across the stakeholder community who have offered similar venues. For example, on Friday, there's an event that will highlight some successful or new approaches to using health IT in improving care transition. So while I can't point to a specific list of this is every idea we've ever received, we are grateful that there's a number of opportunities to highlight a number of ideas, particularly around themes. And if you're interested in learning more about innovations that have been suggested around particular themes or have one to suggest, I'd feel free, again, to use the innovations.cms.gov portal, or since Brian gave you his email address, I'd encourage you to reach out to him.
Okay. Well, let me ask a question more about sort of where would you go? Let's say I am an integrated group, a group of providers, and I'm trying to figure out how I can get comprehensive medication management as part of my offering to my Medicare patients. When you're looking at sort of the list of projects that you've got going, the opportunities, where would you say are some of the places that they can begin to put this into their coordination of medication activities, as I like to call it? How can they integrate that and use a lot of what we have tried to do in the Medication Management Task Force to do? Now, I know you've mentioned things like your community-based transition of care projects, your bundled payment. I just wondered if you might be able to share with us a little bit more specifically, how do we begin to interact to make it viable projects for our patients?
Well, if there was one thing I could suggest to everyone on the call, it would be to build a relationship with your Medicare Quality Improvement Organization in your state, or the QIO. The QIOs are currently focused on a number of activities, and they're actually providing support to help convene communities around care transitions and develop some of these root cause analyses. But they're also focused on improving quality across a number of measures, including cardiovascular care as well. The QIOs have been charged with building a larger network of the HRSA clinical pharmacy and patient safety collaborative teams across the country. So if you were to reach out to your QIO and a number of other state associations, I imagine you'd be able to hear some of the activities that are already happening and to share your innovations with them so they have an opportunity, again, to sort of become part of a particular test in the field. I'd also add one other important caveat. Our solicitations very rarely will say the word pharmacist or the word medication management, though if you sort of drill down into the literature, you'll see that a number of models, for example, in the care transitions world, focus on either improving medication reconciliation or improving medication education at discharge. So the opportunity to look at all of our models and say, hey, there's got to be medication use in there somewhere. How do we reach out to sort of the infrastructure that's being worked with to test the model, whether it's an FQHC, whether it's another organization, and say, we're very interested in helping you improve the use of medications in your program. How can we begin to partner together? I think that's an excellent way for your work and your innovations to bubble up from the field and let us discover them.
Brian, did you have anything to add to that?
No, that's very succinct. Thank you, John.
Okay. Well, John, one of the things you hit on there was we have different things that we talk about when we talk about medication therapy management, like medication reconciliation, which obviously is an important piece, or educating patients about the medications perhaps they've been prescribed. But I guess as y'all are aware, when we talk about comprehensive medication management, we're really looking at the medications in relationship to clinical goals of therapy, and then looking at drug therapy problems, resolving them, and getting to goals. So it goes beyond what you just mentioned, the medication reconciliation and others. So with that, how do we begin is we look at, let's say, some of the existing things we have. We've got MTM, as you mentioned, in Part D. But with Part D MTM, as we know, the eligibility criteria for those MTM services really centers around the drug part. It doesn't center around perhaps some of those patients that, as we know, might be at higher risk or higher cost in Part A and Part B. So I just wondered, are there things that we can begin to do beyond what you've already mentioned to sort of look at some of our existing programs and say, how can we begin to link those to the disease states? And maybe some of the answers is the things like the ABCS program.
So, Brian, if you don't mind my taking a stab at that
Please.
first, I think what I heard you describe very accurately was sort of the breadth of the MTM program and its focus mainly on whether or not service has been offered to Part D or Part D beneficiaries. The new 5-star ratings and quality bonus payments to MA or Part C plans or MAPD plans is sort of a growing opportunity to focus on the use of measures that are weighted to recognize whether or not the medicines are actually being used more often or more effectively, and that is being incentivized via our colleagues in the drug benefit group. I'll say that in addition to that, there are a number of folks who are very focused exactly on the challenge that you're putting out there, Terry, which is exactly how do we begin to start asking ourselves how could improved use of medications in the Part D program lead to reductions in costs or improvements in outcomes in the A and B population, and what mechanisms within the CMS Toolbox that we described might be a good place to begin to investigate, test, or study those. So while I don't have anything specific that I can mention on today's call, I will say that I'm very interested in any and all ideas related to that topic and would encourage you to follow up directly with Brian for any suggestions there.
And if I may, this is Brian, if we look at, John mentioned these community-based needs and the root cause analysis, and you won't have to look far to find out that many of the harm and the lack of effectiveness related to the use of medications, and to make the point that the comprehensive approach to managing medications will ensure that no patient uses the medication without an intended medical purpose, that no medication will be used without understanding the progress toward goals of therapy, and no medication will be used that's unsafe for the patient. With that approach, that'd be my suggestion to how that would fit into those community-based needs and the current studies of what's going on in each community and where the problems lie.
Well, thank you. I have another question from our audience. What can we do nationally to educate patients and providers about the important role of comprehensive medication management? We seem to meet resistance from both about the role and value of our services. Any thoughts about that? Are y'all involved with any of the education part around patients and providers?
Well, I think certainly the Partnership for Patients and the Million Hearts initiatives provide two excellent opportunities for pharmacists to do so. We're very grateful that the Million Hearts initiative will include a CDC-funded pharmacy outreach program. And I'm very lucky today to actually be in Kansas City serving on a panel with the Aging Network, representatives from the hospital community and representatives from the pharmacy and other communities. And we did a similar panel in Washington, D.C. at a very large gathering of the National Association of Area Agencies on Aging. And it was amazing to see someone from the American Pharmacists Association describing the important work that they're doing to bring to bear these changes in better medication use. And you could literally see people across the room and on the panel, start to think about, wow, this could really help my community, this could really help my organization. And by the end of the meeting, they were inviting each other to participate in each other's meetings and write articles for each other's newsletters. So any opportunity that you have to connect, again, with your QIO, your hospital association, your area agency on aging is an excellent way to sort of begin to let them discover the great things that you're doing, and the opportunity to do so around the topics of medication reconciliation, preventing inpatient adverse drug events, or improving the use of aspirin, blood pressure and cholesterol medicines, and smoking cessation strategies is a way to do so in alignment with the National Quality Strategy.
Okay, Brian, do you want to share a little bit about that? Because I know you've been in practice for a number of years at Fairview with physicians, with patients. Just if you could kind of give your thoughts about how were some of the barriers overcome in terms of acceptance of pharmacists or even recognition of how comprehensive medication management could make an impact.
Well, Terry, it's pretty straightforward. I mean, I've cared for over 5,000 documented encounters with patients, and yeah, sure, there's been a few bumps in the road, but overall, you exceed a patient's expectation. And we can only do it one patient at a time in that regard, because a patient likes something, they tell three individuals, and we can only get this to a critical mass or a tipping point by having the contributions of the folks that are participating on this call and those that and the health systems that they're working in. I really believe that we'll get there, but we just haven't cared for enough patients en masse at this point to exceed their expectations in comprehensive medication management.
Okay, I think we're getting close to the end. I have one more question here. It says, funding for ideas or innovations in reducing hospital readmissions, is that for development of technology or implementation? So those are the two questions. And what are the criteria for selection? I'll stop there. There's a number of questions there. But when you're looking at ideas or innovations for reducing hospital readmissions, they want to know what those ideas for funding are. Is it for the technology, implementation, selection, et cetera?
Well, I could take a stab at that and say that the $500 million that the Innovation Center is using to fund a number of activities under the Partnership for Patients on the hospital-acquired condition side is just one mechanism by which we hope to improve medication use in hospitals. And we really hope that that will really provide a nucleus around which other activities can be brought to bear or highlighted and discovered. While we don't have sort of specific funding in that Partnership for Patients funding on that side to pay for the innovations that you're describing, there may be other ways to do so via, again, sort of more of a public-private partnership approach. And then ultimately, again, I feel that the community-based care transitions program again, is a successful or a potentially successful way for us to see some of these innovations in improving medication use to decrease readmission begin to be tested and ultimately discovered to be successful. And there is some hope that the community-based care transitions program perhaps doesn't exist only as a demo, or a program with 5 years of funding on a rolling basis, but rather also becomes part of the permanent landscape.
Okay, perfect. Well, we're about to end here. We're coming to the top of the hour, but I just wanted to thank Brian and John for coming on. I just wanted to also say again, with Brian, you had his email address. This webinar will be up within 24 hours at the PCPCC, so you can go through the slide deck again and listen to the comments. So all of that will be available for you, and that is how you can basically respond. We don't have any more time to answer questions today, but you can always, Brian has said that if you've got ideas, please share them with him, and he's given you his personal email there at CMS. So again, I wanted to thank you. I also wanted to mention to those on the Medication Management Task Force or those that are not on the Medication Management Task Force, please join us. We've got a great stakeholder group, and the next area that we'll be working on beyond our resource document that Brian mentioned is we have heard from many that now we need to look at standards of practice and documentation. So I think this goes right to the heart of the question that we heard, how do we get providers and patients to accept it and payers to accept it? I think if we put forward the expectations of a standardization of the practice that we're saying that we're offering, and then the documentation is standardized, that is how you begin to get acceptance. So that's going to be the next thing that we tackle at the Medication Management Task Force. We've already got a draft document, and I look forward to all of you participating on that. So again, thank you, John and Brian, and y'all have a wonderful day. Don't forget, we got the PCPCC meeting coming up in D.C. next week. If you haven't signed up, please sign up, and we'd love to see you there. Take care.